Welcome to the Coping Podcast, where we share strategies for coping with the stressors of life, especially the difficulties of parenting. And here is your host, Dr. Lee Weiss.
This is Dr. Lee Weiss. I am the host of the Coping Podcast, where I feature top experts on topics like raising healthy children, parenting, and so much more. Past guests include family law attorney Beth McCormick, therapists Dr. Aaron Fromm and Ben Kessler, confidence coach Leslie Randolph, dietitian Lara Field, and many more. Just a quick disclaimer, the information provided is for educational and informational purposes only. This is not intended to provide mental health treatment and does not constitute a client-therapist relationship. The information provided is not a replacement for being assessed and evaluated by a licensed professional and is not intended to replace mental health or medical advice. Before we dive into today's topic, I wanted to introduce today's guest, Dr. Makki. Dr. Mojgan Makki is a distinguished fellow at the American Academy of Child and Adolescent Psychiatry and holds a double board certification in child and adolescent, as well as adult psychiatry. With over 2 decades of dedicated service, Dr. Makki serves as an adjunct faculty and assistant professor at various academic institutions, extending her commitment to mental health by teaching as well as engaging in direct clinical work. In her leadership role at Psychiatry Studio, Dr. Makki has pushed new models of patient care dedicated to improving health and raising mental health awareness within the community. She serves as a trusted consultant to numerous school districts, offering mental health consultations and wellness to support educational teams, community, and students. In addition to her clinical achievements and her educational background, her journey is diverse and marked by her education at Peck's Medical University, Washington University, and UIC, as well as numerous impressive roles such as a medical directorship at inpatient child and adolescent hospitals in St. Louis, founder of Young Child Clinic TIPS at Rush, and she serves on the board of the Illinois chapter of the American Academy of Child and Adolescent Psychiatry and the American Professional Society of ADHD and Related Disorders. So you are very qualified, as we can tell, to talk with us and with parents who may not know that much about the world of psychiatry with children and adolescents. And we really want to thank you for being here.
Thank you so much. And thank you for inviting me and for the wonderful introduction.
Of course. I've learned so much from you, as you know, over the years, both when we collaborate on cases and you've even come and done a lecture for our office for our therapists so that we can, be more informed about the work that you do. You've always been so collaborative, and I figured you could teach some of the parents listening a little bit about medication in children and adolescents. So we're going to dive in. One question that I get a lot from parents is, how do they know when it's really time to consider medication versus just continue with therapy alone?
Mm-hmm. Yeah, that's some of the really good questions. And it depends on the person. It's not always the same. We don't really have a formula to put out there and say, if you get to this point, you really need to consult with a pediatrician or psychiatrist about medication. But it really comes down to impairment and the symptomatology and what effect the symptoms have on the child or on the youth's everyday living. And us, we may see that there is a change, like a child who was otherwise engaged and, ready to go out and about, ready to go out with the friends or go on vacation with family. Maybe all of a sudden we see that they are isolating or they are becoming a little bit avoidance of situations or they seem irritable. So it's either we see there is a change in behaviors and presentations, or it seems like they kind of have the same temperaments, but it's becoming more complicated.
Like more
And those are the
intrusive.
times that we say, let's just get connected to a professional to just
Mhm.
kind of process your observation. And it may not necessarily be that time where you would need medication, but I think it's important when you see a change and you see that the child is not doing as great as they used to do,
Mhm.
make sure that we contact and talk to the primary care physicians, to the pediatricians, even to schools, or if you already have an existing relationship with therapists, to kind of discuss some of your observations with them.
So it sounds like parents, if they're even contemplating medication, but they're not yet sure, it would be okay for them to reach out to a child psychiatrist or an adolescent psychiatrist and just have a consultation, just to get some information and maybe even start monitoring the symptoms.
Yes, I think that one of the areas that's really important for my work, and I dedicate a lot of my time to it, is education. It's not so clear that when we would think that a child is now going from like having some worries to an anxiety disorder. And
Mhm.
so the really best way to manage this is to be educated and to find ways that you can monitor and
Mhm.
find ways that you can keep track of the behaviors.
I like that. And I tell my clients also to monitor, because they might have a really bad day with their child, major tantrums or major anxiety, and think, oh my gosh, this is not normal. We need to quickly, call someone. And, that happens, that we have bad days. But if
Mhm.
it's something that's consistent, if every single day that child is unable to get to school because of debilitating, anxiety about what's to come, right? It seems like it's impacting their
Right.
functioning that's more severe. And I like what you said about, also if it's a marked change, that's important to monitor.
Yeah, so the even for our diagnoses, there is always a timeline. We would never say someone has like panic disorder or anxiety disorder if they have a bad day. Everyone is allowed to have bad days,
Of course.
right? So, for example, for anxiety, for general anxiety disorder, we say that they have to present with the symptomatology more days during the week, more times, more hours during the week, and that this pattern has been existing for at least 6 months,
Hmm.
and that there is an impact on their function.
Right. Right.
So, but it's difficult for some of the parents to kind of know, has it been 6 months? Does it meet the criteria? So sometimes we just make suggestions that keep track of it.
Yeah.
Like make like a quick note on your diary or on the calendar, like this week has been a good week, or this week she struggled 3 days out of the 7.
Right.
So that way you have some idea as what like qualifying the
Right.
difficulty
Right.
so that we can
Absolutely.
kind of be able to keep track of it.
Right. Absolutely. No, documenting a pattern and
Mhm,
documenting the symptoms.
mhm.
So if the parents, they do decide, okay, we're ready for at least to get some information. I know one of parents' fears tends to be, oh my gosh, if I'm starting my, child or even adolescent on medication, is this going to be a lifelong thing that I need to
Mhm.
continue? And so I'm wondering if you can kind of tell me what you would say to parents who worry about that, or maybe even worry that their kids might be dependent on medication. Kind of like, how do you handle that question? It's tricky.
Yeah, I want to say, I hope not. I hope they don't need to take medications all their life. But I
Mhm.
also would say if if they have a disorder and if it's a disorder that they were born, kind of like if someone ends up having a childhood diabetes, and you would think that with doing all the right things, with making sure they get treatment early on, with making sure they get power and education about how to manage the diabetes by exercise and diet, they would probably still need to take diabetic medications or insulin, but it won't have that severe of an impact in their life. So it's really depend on case by case.
Right.
There are some folks and some kids who are born with chronic and severe mental disorder conditions. We have childhood schizophrenia, we have childhood bipolar disorder. So they more likely end up to be on some kind of medication and treatment as they get older.
Mm-hmm.
But the journey can be different depending on what they do with it, whether or not they learn how to manage, they learn how to recognize their symptoms,
Mm-hmm.
they learn how to manage stress, they learn how to be preventive in life and to avoid stressful environments, avoid triggers, like don't enter into the journey of substance use disorder. And just by being more attentive to their life, we are able to help so that we will have a positive or a more positive outcome. In that positive outcome, if it means that they have to take a medication, I think that, yes, it's not perfect, but at least it's a blessing that they're staying stable and they're happy and they're able to reach the goals and dreams that they had in their life.
Absolutely. Well, and it's very interesting what you said about substance abuse, because of course, some people who are not prescribed medication will figure out other ways, to treat their symptoms, and not always in the healthiest of ways. So that's a really good point.
Yeah. And I have to say, Dr. Weiss, that there are also folks that that I start treating like their anxiety at age 5 or 6. And you and I have worked together and we've had some of those little young ones. And really with education, treatment, and helping them to foster healthy life. Healthy life as far as emotionally healthy, avoiding needed stresses, making sure that they have a good nutrition, making sure they have positive activities. We also see that they can grow out of the disorder. They may still be having temperament of like an anxious person and worrying type of a person, but they would recover and they would no longer be in the category of disorders. So they may be able to wean off of medication in a supervised environment.
Of course. Yes, parents should never, wean their kids off themselves. They should always consult with the prescribing doctor. But yes, it sounds like there's obviously success stories where it really makes a huge impact and it's not lifelong, and others where, it is lifelong for good reason. And hopefully, we're getting the child into a trajectory for healthy living.
Yes.
Yeah. Can you tell us a success story, a time that you've treated a child or a teenager, and maybe like what the kiddo came in terms of their symptoms, and kind of what you feel like the medication really helped with? I know you have too many to choose from, but anything that would be helpful to illustrate kind of when it's really effective.
Yeah. So I can think of many good stories. I
You can
think
tell a
that
few.
I think that one thing that comes to my mind for all of them, there's like one common factor with all of them, and that is commitment to treatment, commitment to the relationship, collaboration, that I think that I as a child adolescent psychiatrist, I am there to observe and make recommendations, but it really is a collaborative team, and that I would not be successful in making good recommendations if I'm not getting a good history from my parents, if I'm not getting the parents, like if they're not bringing the kid to the appointments. And I know that all of those take a lot of time and effort, but it's really like putting the village together, bringing schools, bringing therapists, parents, and then putting the patients in the center and providing this 360 holistic support for the child. And I think that plus time is really the key to success. So rarely I have clients that would like see for the first time, and then I'm like, okay, I think this is the diagnosis, and I think this is the medication or the treatment plan we need to do. And it usually takes at least 6 to 12 months to see some reduction of the symptoms. And I think you and I know that if we start medication and they come like in 1 week and say, oh my God, the child is like very different, we always pause and say, okay, let's just hold off and not get too excited, because medication treatment usually takes at least 2 months or so to show its results. So patience. So basically,
So
that's the
patience
first.
is one of the ingredients to success, I'm hearing from the families, and collaboration.
Collaboration, right?
So like willingness to be in the long-term relationship to really get it right.
Yes, willingness to know that this is not a quick fix, and that it needs building relationship, and recognizing that in that relationship, for me who just met the child, I may have some ideas of what it is like, but I rely on my parents and on my family to educate me and to bring like ideas and thought process of what it's really like for them and what is it that they really see. And I think that's some of the things that we do, that we are very much like aligned together, that collaboration and kind of understanding details of the symptomatology. So, for example, I would tell you one of the common chief complaints I get, especially for the younger kids, like grade schooler, is school anxiety, right? And they don't come and say, I have school anxiety. They come and it's like, sometimes it's, oh my God, I have really bad headache, I can't go to school. Sometimes it's, I have really bad stomach. And so it really becomes our job to make sure that what is really the headache? Is it a biological headache? Is the child struggling with some like vision problems, and that they really need to see an optometrist to make sure that they don't need glasses? Or are they having like childhood migraines? And once we rule out all medical causes for the symptomatology, then we start looking at, is it somewhat related to stress? And the child may say, no, I'm not stressed. School doesn't make me anxious. But the child may not really know the connection of what.
And if the parents are doing their homework, that you're assigning them to document and track and notice patterns, and if the stomach aches or the headaches are only happening right before school, that would be an interesting pattern to note. Like
that
you said,
would be a consideration, right? To say that, okay, well, it's happening most days that we're like trying to go to school. It happens on the drop off. But it doesn't really happen during the holidays. We don't have any throwing up episodes. We don't have any headaches during the holidays. And so then the next conversation is to talk about how stress can affect us in so many different ways.
Totally.
Right.
Well, and it's interesting. I always tell kids and adults alike, there's a reason the gut feeling, that people have that expression that, we do feel feelings in our stomachs. And kids especially are prone to feeling, nervousness in their bellies. So it does feel real. It's not that they're making it up, but the question is, right, is it a stomach ache because of, I'm getting the flu, or is it a stomach ache because of anxiety and stress?
Yes. And so remembering that we have stress receptors everywhere in our body. We have it on our skin, we have it in the head, we have it in the stomach, we have it in the heart. And so when the body is very sophisticated, but in some cases not so much. So when you get like a stress, the body is not going to know that, oh, am I in fight and flight mode because I just got a virus and I like ate some bad food? Or am I scared because I see like something that's really scary in front of me? Or is this anxiety? The body ends up recognizing that, oh, I am stressed. And the stress receptors are pretty much everywhere from head to toe. They're everywhere. So one person may have more sensitive stress receptors in the head. Some may have it in the lightheadedness, dizziness, proprioceptive receptors. Some may have it in their heart and they would feel the palpitations. They would go through cardiology and they keep getting EKGs and echoes, and it's like everything is fine. And some may have it in the stomach. So it's not that the person is making it up.
Right.
It's just that that's where they feel the stress.
Right. Absolutely. And do you have a lot of cases where a kiddo like doesn't want to even go to school and this is the presenting issue and, because of the debilitating tummy aches, for example?
Yeah, I mean, I think that most of the, at Rush, where we started that toddler infant clinic, the chief complaints are like two, either school avoidance or, can you guess?
Not school refusal. Okay.
Either school avoidance,
separation anxiety,
or irritability.
Oh, I was going to say separation because they're little. Okay, irritability. Yes.
Yeah. Well, I mean, I would call school avoidance as part of separation,
Yes,
right?
you're absolutely right.
They're just
It's connected.
It's a form. Yeah, it's connected. So irritability or avoidance. And you and I know that there is 3 models of, what is it? Fight, flight, and freeze, right? So we either become, as a child, irritable, where we are exposed to an anxiety situation, or we freeze, and so we go into avoidance. So fight, flight, or we end up with like a panic attack, like an internal panic attack.
Yeah. Right. Not literally running, but, wanting to. Yeah.
Right. Like just having like a panic attack.
Yes.
So those are the manifestations. And so irritability, and having a panic attack is such a difficult experience that we usually end up seeing the fight or the freeze, because our kids are super smart. And so they learn that if I push myself to go to school, I'll end up with a panic attack, right? And like it could be an episode of vomiting. And that's no fun because everyone is looking at you and everyone is, there may be some judgment around there and there may be some embarrassment around there. And that makes it even more difficult to go back to school. So it becomes mostly with fight, irritability. I don't want to go, make me go, yelling, screaming, fighting.
Yeah, power struggles with the parent, making them go.
Or freeze and avoidance.
Sure. And if they avoid, kind of the thing that's making them nervous or the thing that's scaring them in some way. And they get away with it. Sometimes very well-intentioned parents are like, oh my gosh, let's take the day off, but then they never really can face the fears if it becomes a pattern. Right. And so they never can get out of the cycle because
Right.
they're just rescued from it. And immediately when the parent says you don't have to go to school, they're like, oh, whew, okay.
And so when you think of medications, like if we want to circle it back to like, when do we think medication is right? Let's say that these fights and freeze moments are so extreme that we are not able to talk our kids into going to school, right? Because nobody wants to go through like feeling of that extreme anxiety, right? It's super uncomfortable feeling. And even our adult patients struggle tolerating that feeling. And of course, kids have less ability to tolerate adverse feelings and situations. They haven't grown those protective mechanisms, so it's really difficult. So we use medications when appropriate to lower some of the fight and flight responses. And going back to like success stories, they come in and they're like unable to go to school because they either become so irritable or they end up having so many like
severe pain or something.
Severe or vomiting incidences. And so we then use the medication to lower some of those fight and flight responses. And we recognize that this anxiety is not something that you take an anti-inflammatory, you take an aspirin or you take like Advil or something and that it goes away. It's the process. So we use the medication to lower some of the fight and flight symptoms, to lower some of that upset stomach. But we also recognize that the child will likely continue to have to feel anxious.
They'll have some level of anxiety, but it isn't, maybe it was a 10 and you lower it to a more manageable number so they can at least get to school because they want to, but they can't if they're in that panic mode.
So let's say if it's at 10, good idea to put it on a number. So if it's at 10 or at 12, we hope the medication can lower it to like, let's say 6, 6.5. And then we say, now the part of work that's important is to engage in therapy so that we can learn how to use our mindfulness abilities and exercises, how to use our breathing, how to use detouring ourselves from the anxiety thoughts to calm the body.
Right.
And that way we can actually go to school and be comfortable to still feel the anxiety, right?
And still learn, so they could be, okay enough to learn in school. Yeah.
Right.
No, I think that's, it seems to me that's a common one, that the anxiety leads to avoidance and potentially school refusal or school avoidance. Or I have a kiddo I've worked with who just has really severe separation anxiety symptoms, but only relates to, drop off at school. And, obviously medication really helped in her instance because every single day it was consistent that she would be tardy. And she was a good student. She was smart. She was motivated. She was a good kid who wanted to be there, but couldn't get herself there. And all of the little challenges we did and all the tools didn't seem to be enough. But with the medication, it wasn't a magic fix. But then she was able to really actually use the tools that she knew all along. So that was a powerful one for me.
Yeah. To lower it so that then they can use the non-medicinal coping strategies to further empower themselves. We always talk about how even with medicine, we would expect the child or the patient to still feel anxiety.
Right.
And let's say, like, if we have someone who has phobias, let's say there is phobia of height, there is phobia of elevator, there is phobia of getting on a plane. And now we have the 17, 18-year-old who really wants to go to college on one of the coasts,
Right.
but the phobia of the plane is really so difficult that they're actually reconsidering the opportunity to be at the school that they want to be.
Right.
So those are the times that we say, let's use some medication to lower some of the fight and flight responses, but then you still have to work in therapy to do some like exposure management,
Right.
because you're still going to feel the heart pounding, the butterflies running,
Yes.
and then you can use some of the breathing exercises or the distracting your thoughts from anxiety to manage in the moment.
Absolutely. Absolutely. No, that makes a lot of sense.
So when a family comes to you and the parents say, "Okay, I think we're ready," what are some of the areas that parents should be prepared to talk to you about so that you can best formulate the treatment plan? And also, is there any kind of new cool research or technologies that you use to figure out which medications might respond better?
Mhm. Um, how much time do we have?
10 minutes or so. Yes.
All
Just a
right.
glimpse.
So I think, yes, there are some directions and more like advances in science. We still have a long way to go. And in that sense, that we still have a long way to go, one factor that I think is really important is to recognize that, let's say I have a 5-year-old, 6-year-old, and I look and I say, okay, this looks like ADHD, or this looks like anxiety. One factor to always be mindful is that it may look like something else in a year or in a two. And so a child is constantly changing and growing. And so it's really important to keep the diagnosis open and to never say that this child has anxiety disorder and then like close the door to any other possibilities or changes in the diagnosis. And to also recognize that if those changes occur, it's not because the clinicians made the wrong diagnosis at the time. It's just because the child's psycho growth, the neurobiological growth, is as such that it may look like it's ADHD at one age, and then it may become anxiety at another age, or they may grow out of it. So always keeping the door open for getting more education about diagnosis and the symptomatology, and keeping that always in the back of our head that matters may evolve. So with that said, the reason I say this is that if I think it's an anxiety disorder, but like I start with some medications to target anxiety and I'm not getting the usual response that I want to get, I have to go back, and these are in like practice guidelines. I have to go back and redo my evaluation and make sure that I did not misdiagnose or that I didn't miss anything in my diagnostic formulation.
Mhm. That makes sense. And a lot of times they look the same, right? Their symptoms that
Mhm.
overlap, and it is hard to tell.
Right.
So
Especially
how they
in kids.
respond, yeah, and so how they respond to a medication is more indication, more information, to really understand what's actually happening.
Right. But some of the factors that is really helpful is family history
Mhm.
of medical and psychiatric disorders. So, and I'm relating to, not just the not just the siblings or the parents, but also like grandparents, great uncles, and just getting a good history and or bringing that family history to the appointment. If you've had family members who struggled with anxiety, obsessive compulsive disorders, what type of treatment has helped them? Because there is facts and science to say that if a sibling or a parent has responded best to certain type of medications, it's likely that the child would respond to those. And then also for us to know a diagnosis, if I have family history strong of ADHD, I may think that what looks like anxiety may actually be ADHD. So it's really important to have that family history, as well as the medical family history. As we know, some autoimmune diseases, some patients with autoimmune diseases are more likely to have psychiatric disorders. Autoimmune diseases such as diabetes, thyroid diseases, all the way to arthritis types of disorders, skin conditions with like lupus types of disorders. So really bringing all the family history. The more you have, the better picture the clinician, the child adolescent psychiatrist will have. Then there are some and we always say, whatever decision is made, make sure that the medication is started at the low milligrams. So start low, go slow. This is not a marathon.
Right.
Or actually, this is a marathon.
This is not a sprint. Yes. Makes sense.
This is not. If we start at a high dose, there is more likely that our patients will have side effects. And then we end up saying that they didn't tolerate the medicine, and you basically say no to one medication where the real problem was that it started too strong and too high. And so they ended up having side effects to it.
Right. That makes
sense. So start slow, go slow. This is a marathon, not a sprint.
Right.
I have folks that come and say, what about there is like a test to see if my child would do better with like one medicine better than other. And we know that there are different companies who do that. And I would say those tests can help. It's usually helpful if we have gone through a couple of different treatment strategies, and for one reason or another, nothing either has worked, or we end up with side effects even at the lower doses. Yes. So those are some of the tests that we can see. Are these patients metabolizing the medications differently than the average population?
Right. So it's not like something you go to right away, but it's in your toolkit. If someone's not responding the way you would expect, or you're really not getting something that works after several medications, then you can have this. Okay. Yeah. What about with ADHD? I was reading about some recent research and brain scans to be able to diagnose versus just having, typically we do psych testing and we do, again, a thorough psychiatric consult. Where is the field in terms of the scans at this point?
Yeah, it's really moving forward. We are not where we can really rely on those for treatment. It's still in the research part where we are really trying. We are seeing, like, if we do functional MRI, fMRIs, or glucose MRIs, we see that folks with ADHD have different activities in different parts of the brain. We see sometimes we see the same with like OCD, we see it with tics and Tourette's, we see it with many of the psychiatric and medical conditions. But we are still trying to group them together. And so we are not at the place where we can say, okay, if there is more signaling on the left hippocampus, that means you respond better to X type of treatment. We are not there yet. We are still kind of putting them in different categories.
It sounds very exciting and promising, but still in the research phase is what you're saying.
Yeah.
Okay. So we have to be patient and, we're not in the sprint part. We're still in the marathon.
We're not in the sprint.
Okay. I guess my last question for you is, I imagine parents are worried about putting their kids on medication and worried about side effects. Can you speak to, what are common side effects for, kids with, again, who are getting treated for anxiety or depression? Things that, you would share, and how scared should they be? Is it smaller than it used to be? People obviously are very, I would say, hesitant.
Yeah. I think the first part to be really attentive is education. So in our clinical work, um, we see folks that are more conservative, and then we also see folks that are more comfortable about starting medications and, children, adolescents, adults, all of that. I think that it's really important to have good education and a good understanding of what is the role of medication. It's not a good idea to overuse medication. It's not a good idea to underuse medication, but really to have an understanding of what is a good place for the use of medication. What should we expect from the medication? What is the course of treatment? If I start this medicine now, we know with some of like our medical treatments with antibiotics, we know that if you're taking an antibiotic for a tooth infection, you take it for 15 days. If you're taking it for a bronchitis, you take it for 4 or 5 days. So just being knowledgeable, having an education of what is the course of treatment and what are some of the symptoms that we are monitoring, and what is this monitoring process? Should I expect to see recovery, or is it just reduction of the symptoms? So I think for all of our parents, I recommend to be patient with the process and dedicate your appointments to get educated and to ask all of these really, really important questions. And don't be too quick about getting a prescription or starting a medication unless there is something that's life-threatening that can't wait. But if we have a child who's been through this for a year or so, making sure that we engage the child into this as to helping the child to understand, why am I taking this medicine? What is this medicine going to do? What is my role as a child in this picture? And so it requires a lot of conversation and just to be patient with it and to make sure that our children understand that we are not thinking that they're not good enough.
Oh,
and that the medicine is not there to change
or that they get
them.
credit. The medicine gets credit. Let's say if they're successful going to school, like it's not, that helps, but no, you're still doing the hard work. You still get credit. Yeah.
Right. And, like I hear sometimes my kids come and complain and say like, I was having an anxious day and like I was asked, did you take your medicine? So just little things like that to recognize that even with medicine, we're human beings. We have to have ups and downs. If we don't have ups and downs, we should worry, right?
Right. Because that's what prepares us for future ups.
Which can be one of the side effects of medications. We can talk about that on our next podcast.
For sure, part 2. Okay, how can people find you? What is your website? Just so people know kind of where you're at.
Yeah, so I am Psychiatry Studio, and I am blessed to be working with some of my dear colleagues from St. Louis, where I did my initial training at WashU, and my amazing staff, Sarah and Jackie and Gwen and Lori. And without them, I wouldn't be able to do all the cool stuff that we do. So we are in St. Louis and in Chicago, and my focus right now is actually being at the schools and providing education and support for the school systems. But that's who we are. But also for just general education about child and adolescent psychiatry, families can go to American Academy of Child Adolescent Psychiatry or the Illinois chapter, where I am a board member. And the American Academy has a really nice website, and there is a part that is facts for families.
Mm-hmm.
And there you can look at some of the common questions and concerns about children's psychiatric conditions and disorders.
Wonderful. Well, thank you again so much, Dr. Makki, for being here today. Everyone, please check out more episodes of our podcast. Go to copingpartners.com and click on podcast and articles. And thank you, as always, for tuning in.
My pleasure. Thank you for being such an amazing partner through my journey. And thank you for inviting me.
Likewise, it's been a pleasure.
Thank you for listening to the Coping Podcast. We'll see you again next time, and be sure to click subscribe to get future episodes. And check out our podcast page at copingpartners.com.